Dr. Lalasa Varanasi.
Thank you. Good morning.
Yeah, good morning. Good morning. Yeah, good morning, all those my dear friends in the United States, and good evening for those who are there in India. And welcome again to this weekly webinar, which is the 26th in a row. And I welcome each one of you for this morning, this video conference. And first of all, let me apologize, Dr. Lalasa Varanasi, for making us get up at 3 a.m. in the morning and to share her experiences with us. And I profusely thank Dr. Ram Kairam for not only facilitating this particular program, but also by inviting Dr. Lalasa Varanasi, but also for providing the platform. So as you are aware that in the last 26 weeks, we had a series of sessions. We had a very illustrious speakers who shared their knowledge, and which has really made a difference in the management of COVID-19 patients in the district of Visakhapatnam and in the state of Andhra Pradesh. I'm very glad that my friends abroad have contributed significantly for empowering our doctors with the knowledge on COVID-19, and accordingly they have all changed some of the concepts and improved on what they have done in the earlier period. So this is what is the reason why we have initiated this particular program. And the good aspect of this is that this has been going uninterrupted for the last 26 weeks. Probably the only medical college in the entire country. That's what I heard from some of the friends. And Dr. Lalasa Varanasi, a clinical assistant clinical professor in the Division of Nephrology at University of California, San Francisco, a very young and dynamic nephrologist. The reason why we have invited her is to share her first-hand information as to how she dealt with these cases of COVID-19 with kidney injury, kidney disease, and also what can we expect later in their lives once they become better, once the COVID-19 subsides. Are they going to have the permanent damage of their kidneys, and how this particular pandemic changed the kidney disease over a period of time. Before I ask Dr. Lalasa Varanasi, I wish to request our Dr. T. Raviraju, my teacher, and the former principal, director of medical education, and also the vice chancellor of NTR University of Health Sciences, a very famous nephrologist by himself, to say a few words and start the proceedings. Over to Dr. T. Raviraju.
Thank you very much, Dr. Sudhakar. Good evening to all those in India, and good morning to very early good morning to all those from the United States. I thank Sudhakar profusely for giving me this opportunity to moderate today's session. And I'm extremely happy that Dr. Lalasa Varanasi is the speaker today. And one of the important topics of today's era is the kidney disease because of COVID. And though I am not personally acquainted with Dr. Lalasa Varanasi, but I know the family for a very long time. I know her uncles very well. I know her father too. And also I'm very happy that she comes from such an illustrious family. I'm sure she has the tradition and also the individual talent, and that is because that's why Dr. Sudhakar has invited for this lecture today. The second reason why I am also very happy today is the University of California, San Francisco, after doing his residency and the fellowship from New York, residency of course with Dr. Chilimori. My son went to University of California, San Francisco. He did his transplant nephrology there 3-4 years ago. And that's one of the reasons why I have. And I have a good friend, Flavio Vincenti, who is an authority on renal medicine. And of course, kidney transplantation is a good friend of mine. So with all this, I have a special affinity for University of San Francisco, University of California, San Francisco, UCSF. So today's topic is, as I understand it, is COVID and kidney disease. I hope she will speak mostly on the problems related to COVID in the delivery of nephrology care to the patients affected by end-stage kidney disease, acute kidney injury, and chronic kidney disease, and possibly hypertension. As all of you know, this series we have started a long time back, and I congratulate Sudhakar for taking this forward uninterruptedly. So many sessions have been done. And the first session, if those who are following this right from the beginning remember, was made by me, and it is the extra pulmonary manifestations of COVID-19. So this is again an extension of those extra pulmonary manifestations. And sure, Dr. Lalasa will take us forward with all what has happened. So this is a dynamic process. This has been going on, evolutionary. So over a period of years, we are coming to know more and more about the kidney problem in COVID-19. As all of you know, it is COVID-19, it causes substantial respiratory pathology. And not only it can produce respiratory pathology, there are several extrapulmonary manifestations, like which include thrombotic manifestations, myocardial injury, arrhythmias, acute coronary syndrome, gastrointestinal symptoms, hepatocellular disease, kidney injury, acute kidney injury, and also various other things like hyperglycemia, ketosis, dermatological to name virtually every system in the body is affected. This is because, as you know, this is the ACE2 entry pathway. The virus enters the body through the ACE2 receptor, and the ACE2 receptors are widely distributed all over the body in various organs, not only in the pulmonary system, but also in the kidney. And not only the entry of the virus and also the direct toxicity of the virus on various organisms, you have the thromboinflammation and dysregulation of the immune system, hyperimmune response, all of them causing various manifestations. Not only that, a maladaptation of the ACE2 pathways is one of the reasons why people develop several manifestations apart from the respiratory failure and symptoms of respiratory disease. So knowing all this, if you have the kidney disease, we will have the COVID patients getting affected, or the kidney patients getting affected because of COVID for various reasons. One is they may be having an end-stage kidney disease, or they may have chronic kidney disease already and have hypertension, or they may be post-transplant patients, or they might develop acute kidney injury as a part of COVID infection. So people with kidney disease are more prone for COVID infection, not only because of the kidney disease, but these people have several comorbid conditions. They are usually elderly people. They have hypertension, they have diabetes. So all these things predispose them. They will increase the mortality and morbidity in these people. And those without kidney disease also can have a kidney failure because of COVID. And the problems we face in India, we have been seeing this for a long time, for almost 1 year now. And the problems which we have been seeing are people were not able to come for dialysis because of lack of transport. The relatives were not bringing them to the hospital. We were not well equipped in the hospitals to handle these patients. So we made general guidelines from the Indian Society of Nephrology, for which I was the past president. So I'm circulated to the entire country how to handle patients of chronic kidney disease, what are the guidelines. Just as Dr. Lalasa might be knowing that that in the International Society of Nephrology and the American Society have given guidelines. So like that, we have handled effectively, and the mortality has been reduced. The post-transplant patients also, we have circulated a lot of information to them regarding the basics how to handle the COVID infection. So with this brief introduction, I will request Dr. Lalasa to go on with her talk, so that at the end of the talk, we will have some discussion, and also we will answer the questions from the chat box. And I will have a few questions for her too. And I invite Dr. Lalasa to give her talk.
Good morning and good afternoon, everyone. Thank you so much for the lovely introduction, Dr. Ravi Raju, and for the invitation to be here, Dr. Sudhakar, Dr. Kairam. Hopefully you can sense my enthusiasm through my Zoom background. I just want to tell you as a disclaimer that I'm not a researcher or an expert in this field, but I wanted to share with you my observations and readings and clinical experience in dealing with COVID-19 in a large academic institution like UCSF. I'm also not familiar with the Indian medical system or nephrology practices necessarily, so please excuse me for my lack of awareness if something sounds foreign to you. I have no disclosures relevant to this talk, and this is a brief outline of what I'll be going over. So first, I will give you some background and epidemiologic information, go over the pathophysiology of acute kidney injury and COVID-19 infection, and then focus on the clinical manifestations and management of COVID-19 associated kidney injury. There are some special considerations to consider in dialysis requiring kidney injury, which are very important. And I will also mention on a couple of things on how to manage resources in a pandemic where resources might be scarce. And then I will end with discussing the long-term sequela of kidney disease after kidney injury related to COVID-19. I didn't think I would have too much time to focus on kidney transplant patients or end-stage kidney disease patients, but I will mention at the end if I have some more time. So I wanted to start out with some background. So this is an updated map from the New York Times, which gives you an idea of the distribution of cases of coronavirus in the US. This was updated as of last night. And as you all probably know, at the beginning of the pandemic in the US last year, New York City was the epicenter. And now New York still has quite a few cases, but you can see in the dark red that Southern California, Arizona, parts of Texas and South Carolina are really seeing surges in their censuses. Here on the left side, you can see a graph showing the cases of coronavirus in California from March 2020 to now. And this was also updated as of last night. You can see that the West Coast wasn't actually that affected early on in the pandemic when New York was hit the hardest. And now over the last 2 months, we're seeing many more cases. On the right side, there is a map of California showing the distribution of cases. And in San Francisco County, there are about 29,600 confirmed cases, or 1 in 29 people who are confirmed to be positive, and that's about 32 deaths per 100,000 people that we're seeing. This is information from the San Francisco Chronicle. Within UCSF, as of January 21st, we had about 120 patients total in the UCSF health system at the 2 main hospitals, UCSF as well as the Zuckerberg San Francisco General County Hospital. And we're seeing about 300 new cases daily in San Francisco. You can see there that the percentage of asymptomatic case positivity is 1.8%, and symptomatic case positivity is 9.5%. And actually this week, UCSF Health has seen an improvement in hospitalized cases of COVID-19 positive patients, but still San Francisco remains at a level 4 high alert state. And out of these inpatients who are COVID positive, I don't have an exact number of how many of them have kidney disease, but I will say that I know on our nephrology consult list, at least 20 of them out of the 66 at the main UCSF hospital have either end-stage kidney disease or are on CRRT for acute kidney injury. The number is dynamic, so it's hard to give you an exact number. Next, I just wanted to go over briefly the definition and staging of AKI. Many of the studies that I'll be referencing use the KDIGO definition of acute kidney injury. These were established in 2012, and as you can see, stage 1 is quote unquote mild AKI, and stage 3 is severe, with patients usually requiring initiation of dialysis. So in terms of the incidence of acute kidney injury in COVID-19, we have seen that compared to reports in China, the incidence of acute kidney injury in the United States is much higher. And on the right side, I've listed some of the very early studies that were done looking at the incidence of acute kidney injury and dialysis requiring kidney injury in various countries. And the ones in red are some of the larger studies, and you can see that the incidence of acute kidney injury is quite variable between each of these studies. And I think some of this variability may be due to the fact that the investigators were maybe using different definitions of AKI. They were studying different populations. They had different sample sizes, et cetera. And so you can see in the table that in the study of over 5,000 patients, for example, the incidence of acute kidney injury was about 36.6%, and then the use of kidney replacement therapy among those patients was about 5%. Presumably, the incidence of acute kidney injury is likely even higher than the reported numbers in the studies, based on the presumption that some of these patients who presented with elevated serum creatinine already had acute kidney injury when they were coming into the hospital. In terms of the timing of the onset of kidney injury, there's some variation in the studies that were done in the United States and China. Many of the studies in China reported a median onset of kidney injury within 7 to 14 days of hospitalization, whereas in the US, we've been observing much earlier incidence of kidney injury. So there was a study published in Kidney International in May of last year, which looked at 13 academic and community hospitals in metropolitan New York City between March and April 2020. And you can see based on the graph here that in the there's a clustering of kidney injury cases right upon admission and within 24 hours of hospital admission. And then there's a spike again later on in the hospital course, starting at day 8. And what has also been observed is that there was a substantial clustering of kidney injury events at the time of intubation and mechanical ventilation. So of the patients who required ventilation and developed acute kidney injury, 52% of the patients had onset of acute kidney injury within 24 hours of intubation. and the median time from mechanical ventilation to initiation of dialysis was only 0.3 hours. So these are some of the risk factors for AKI. As Dr. Raviraju had mentioned, there are many risk factors that have been identified, and some of the clearest risk factors for the development of AKI are indicators of severe COVID-19 infection, such as the need for ventilator support or vasopressor drug treatment. Some markers, such as the initial respiratory rate, white blood cell count, lactate dehydrogenase, and neutrophil lymphocyte ratio have been shown to be predictors of severe kidney injury. And the patient's comorbidities, including hypertension, diabetes, chronic kidney disease, heart failure, and peripheral arterial disease are all have all been identified to be risk factors for kidney injury in COVID-19. Older individuals and men were at greater risk, and there has been some variability between studies, so it's unclear as to whether elevated body mass index is also another risk factor specifically for developing kidney injury. So this is an interesting study that actually just came out in CJASN this month. And this was a study, a national study looking at various hospitals serving veterans. So this included Veterans Affairs facilities and looked at patients who were hospitalized with COVID-19. You can see here that the majority of the patients who were with acute kidney injury were in Arizona, California, Florida, Illinois, Indiana, and on the East Coast, in New York, New Jersey. And basically in this study, there was a lot of geographic variability that was observed in the rates of acute kidney injury. And the analysis that they did showed that some of the variability may have been explained by things like African-American race, a composite measure of each geographic location's socioeconomic disadvantages, rates of obesity that were different in different areas, rates of diabetes, hypertension, chronic kidney disease, etc. And so I thought this was interesting that there's such a geographic variability in rates of acute kidney injury. In terms of mortality, we know that people who have acute kidney injury have a high rate of mortality. Again, in all of the studies, there is so much variability that it's hard to give an exact percentage to this, but based on the early studies in the United States, this is estimated to be about 35 to 41%. So again, in a study looking at 13 hospitals in New York, this graph shows you the distribution of admitted patients in yellow, discharged patients in teal, and then expired patients in the dark purple. So they studied over 5,000 patients, and they found that among the patients with acute kidney injury, about 35% died in this study. And again, the risk factors that they generally found were consistent with what I had just mentioned earlier. So markers of severe multi-organ failure and severe COVID-19 infection were the clearest risk factors in this study. And similarly, a systematic review and meta-analysis of 6 studies in China also found that acute kidney injury and COVID-19 was associated with at least a 3-fold higher risk of death. So this was an interesting study. This was done in 3 hospitals in the Bronx in New York City, and the Bronx is an area that's unique because the hospitals there serve patients who are usually underserved and at a socioeconomic disadvantage. So this study looked at acute kidney injury in hospitalized patients with and without COVID-19. And as you can see in the pink boxes that are highlighted, they compared the rates of acute kidney injury and specifically dialysis requiring kidney injury, or RRT, for renal replacement therapy. And they compared those rates between patients who were COVID positive, COVID negative, and then a cohort which included patients from the year prior who were admitted to those hospitals. So they compared the incidence, risk factors, and outcomes of AKI in this large New York City health system. And again, in this study, they found that male sex, Black race, and older age were associated with AKI, but these associations were not necessarily unique to COVID-19. And in this case, select initial vital signs at hospital admission and inflammatory markers were predictors of severe acute kidney injury. And so the primary outcome was incident acute kidney injury, and the secondary outcome was the composite of the need for kidney replacement therapy or mortality. And so in this case, of the patients who tested positive for COVID-19, 4.9% required dialysis compared to 1.6% of those who were negative for COVID, and then 0.9% in the historical cohort from the prior year. Now I wanted to go over some of the clinical manifestations of AKI and then move into the mechanisms of renal injury. So what most studies have noted is that proteinuria is often transient, although the mechanism is not really known with certainty. There's been variable urine sediment examinations. Many patients have proteinuria and hematuria, and the severity of the proteinuria and hematuria are associated with an increased risk of mortality in patients with COVID-19. Although the hematuria, it's hard to say whether it's of renal origin because, as you know, critically ill hospitalized patients may have Foley catheters or other reasons to have hematuria. So these are some of the most recognized mechanisms and patterns of injury to explain COVID-19 associated kidney injury. So as Dr. Raviraju had previously mentioned, direct viral infection of the renal epithelium is thought to be one mechanism, and I'll talk about that. Hemodynamic changes, acute tubular necrosis, which is one of the most common manifestations, rhabdomyolysis, and then glomerular vascular disorders also occur, though they're pretty rare. This is just a graphic illustrating the fact that the mechanism of injury is just very complex and involves multiple organs, and so we will go over this in more detail. So this shows you the entry of the SARS CoV-2 virus into the kidney. And basically the receptor for this has been shown to be the ACE2 receptor, angiotensin converting enzyme 2 receptor, which is actually expressed in the kidney much more than in the lungs, specifically on the brush border apical membrane of the proximal tubule, and also at lower levels in the podocytes, which could explain some of the manifestations that we see. Concrete evidence that the ACE2 receptor is associated with the entry of the virus into the kidney. This was confirmed around March of last year. And actually, this SARS CoV-2 virus, which is responsible for COVID-19, has a higher affinity for this ACE2 receptor than the original SARS CoV-1 virus that was responsible for Middle East respiratory syndrome back in around 2003. So essentially what happens is the virus, there's membrane fusion of the virus, and then the host cell is activated after binding. It enters through receptor-mediated endocytosis, and then the viral RNA is subsequently released into the cytoplasm, establishing the infection. So once the virus enters through the ACE2 receptor, it actually functions such that it downregulates ACE2 expression, and basically the angiotensin 2 is upregulated, and there's dysregulation of this whole renin-angiotensin-aldosterone cascade. And there's this imbalance between angiotensin converting enzyme and angiotensin converting enzyme 2. And essentially what you have is severe organ injury as shown here. There's been some discussion of, for this reason, as to whether RAAS inhibitors like ACE inhibitors or angiotensin receptor blockers are safe for use in COVID infection. And ultimately, what most of the studies have found is that there's no there's no reason to discontinue these medications routinely unless indicated for other reasons. I did want to mention that the SARS-CoV-2 virus has been isolated from urine samples of infected patients, suggesting the kidney is a target of the virus. And just based on our experience at UCSF, because there's still a lot more to be known about this and what this means, typically for general nephrology consultations of acute kidney injury, where we perform our own manual urine microscopy and sediment examination. But for patients who have tested positive for COVID, we have been avoiding that just as a safety precaution. And usually the clinical presentation is very suggestive of what's going on and the pattern of kidney injury. So moving on to hemodynamic changes and pre-renal acute kidney injury. As you can imagine, people who are ill with COVID-19 may have decreased fluid intake, insensible losses due to fever. Many of them get diarrhea. And then in an effort to keep their lungs dry and prevent volume overload, they may be treated with diuretics, which may lead to volume depletion. As you may have heard, there have been reports of myocarditis, myocardial injury, cardiorenal syndrome with COVID-19. And so that leads to hemodynamic alterations, which can affect kidney function, of course. And then I also wanted to mention some of the hemodynamic alterations that mechanical ventilation can cause. So whenever you have someone who is on mechanical ventilation, that basically that causes increased intrathoracic and right atrial pressure, leading to decreased venous return as a result of the hyperinflation. You can get increased pulmonary vascular resistance, which leads to decreased cardiac output. And this is, of course, all variable depending on the lung and chest wall compliance. And on the right side of this illustration, you can also see the role that cytokines play in this lung-kidney crosstalk. In fact, we know that fluid overload can cause, obviously, kidney injury and lung injury, but ARDS after ischemic AKI is also mediated by interleukin-6. So that has been shown in multiple studies. So this just illustrates kind of this organ crosstalk, meaning that the kidney is affected by dysfunction in any other organ, and it's quite common to see multi-organ failure in COVID-19. So acute tubular injury is the most common renal pattern of injury associated with COVID-19. It occurs in the setting of multi-organ failure, sepsis, cytokine release, and drugs with known nephrotoxic potential, but that does not necessarily require the presence of hemodynamic instability or shock. On pathology, which I'll show you a bit later, you can see loss of the brush border, tubular cell necrosis, vacuolar degeneration, glomerular collapse, fibrin thrombi, and then on electron microscopy, there may or may not be podocyte injury as well, and that explains the proteinuria in these patients. The management is primarily supportive, as you know, just as in any other cause of tubular injury, and we'll focus on some of the special considerations in dialysis requiring AKI afterward. And a lot of the postmortem and kidney biopsy studies in COVID-19 patients have shown that this is the most commonly observed histologic manifestation. So here in panel A on the left side, you can see the arrows pointing to proximal tubules with the flattening and loss of the brush border. And then on panel B on the right side, you can see vacuolar degeneration as indicated by the arrows. The asterisk indicates, don't know if you can see my pointer here, but that indicates necrotic epithelial cells in the tubular lumen. And then these arrowheads point to erythrocyte aggregates that were seen obstructing the peritubular capillaries. Next, I wanted to mention rhabdomyolysis, which actually we know is a common cause of, a well-known cause of kidney injury, but specifically in COVID-19, it's actually rare, and there are just case reports mentioning this. But I wanted to highlight this just because it is a life-threatening complication of COVID-19 and requires a high index of suspicion from us as providers. It should be suspected in patients with disproportionate myalgias, muscle weakness, dark urine, unexplained hyperkalemia, or metabolic acidosis. And of course, acute renal failure is the most severe complication. As you know, it's associated with many things, including trauma, drugs, toxins, viral infections, and in fact, influenza is thought to be the most common viral cause of rhabdomyolysis. And in early COVID-19 cases, there were reports that hydroxychloroquine and or Plaquenil and oseltamivir or Tamiflu were implicated or associated with rhabdo. And the proposed mechanism of this in COVID-19 is thought to be due to direct viral invasion of muscle tissue, in addition to the cytokine storm. So on the left here, you see the arrows pointing to pigmented cast that you would see classic for rhabdo. And of course, the management is typical, as is for any other cause of rhabdo. So first you identify the underlying cause of muscle injury. Aggressive fluid resuscitation is the cornerstone of therapy, although as you may imagine with COVID-19, especially if someone has severe respiratory failure, ARDS, this may be difficult to manage, and a lot of them will require dialysis. And then urinary alkalinization, in theory, has been proposed to help with rhabdo, and basically by preventing the nephrotoxic effects of myoglobin and hyperuricosuriasia. But in studies, it hasn't necessarily been proven to improve outcomes. One thing I wanted to highlight is propofol infusion syndrome. This condition is relatively rare, and we may not see it often in our practice, but it does have a high mortality. And of course, many COVID-19 patients are intubated and sedated on propofol. And so these patients are at particularly high risk of this. This syndrome is characterized by unexplained metabolic acidosis, rhabdo, renal failure, cardiac arrhythmias and dysfunction, hypertriglyceridemia. As you can see, the propofol itself is very lipemic. You can see hyperkalemia, hypotension, and transaminitis. And typically the classic scenario is that you may have someone with acute renal failure, for example, due to acute tubular necrosis from sepsis or just the cytokine storm from COVID-19. You start them on dialysis or let's say CRRT, continuous renal replacement therapy. And after a few days, they're stable, you've achieved metabolic control, their labs are stable, and all of a sudden you start noticing hyperkalemia and metabolic acidosis that is rapidly developing, requiring you to adjust your dialysate. And so in this situation, just always have in the back of your mind that this propofol infusion syndrome could be a possibility if there's no other reason to explain the metabolic derangements. This is a complicated mechanism by which propofol causes this type of injury. But long story short, essentially there's a defect in the beta oxidation of fatty acids. There's fatty acid accumulation in organs, and this specifically can lead to cardiac arrhythmias. There's inhibition of oxidative phosphorylation and the electron transport chain, and this therefore leads to type B lactic acidosis. And then there's blockage of beta adrenoreceptors and cardiac calcium channels. So the treatment really is to recognize the syndrome and immediately discontinue propofol, use an alternate sedative if needed, and treatment is supportive. One thing to know is that because the solution itself is lipophilic, it has a large volume of distribution and is actually poorly cleared by dialysis or CVVH. So these people typically require prolonged renal replacement therapy. Another less common manifestation of COVID-19 related renal injury is thrombotic microangiopathy. This particular one that I've shown here is actually the first reported case. And it's actually not clear whether there's a direct pathogenic role of the virus that's associated with the thrombotic microangiopathy, or whether there's a latent complement defect that's unmasked, which leads to widespread endothelial damage and microthrombi in the kidney. But here you can see in this patient on day one, they were treated with hydroxychloroquine and low molecular weight heparin. Their hemoglobin and platelets and creatinine were relatively normal. And then they were treated with various therapies for the COVID-19, intubated on day 17, and you can see their hemoglobin and platelets are starting to drop, and the creatinine has significantly gone up from day 16 to day 17, from 5 milligrams per deciliter to 2 milligrams per deciliter. So this person required dialysis starting on day 18, and then there were schistocytes seen on the smear. They did a kidney biopsy, which I will show you, I think. And then in the end, they were actually treated with eculizumab, but unfortunately the patient ended up expiring. So here's a picture from this case of thrombotic microangiopathy. And in panel A on the left top corner, it's a PAS stain, and you can see diffuse coagulative necrosis with widespread glomerular microthrombi. And then in panel B here, this is a normal H&E stain. You can see this glomerulus just looks abnormal, has multiple microthrombi, and actually even the proximal tubular cells just look very abnormal. And then in this silver stain here in panel C, there's a thrombosed glomerulus with a large thrombus here in the vascular pole and the arteriole. And then finally, in panel D on the right bottom, there's an electron micrograph with extensive fibrin deposits in the capillary lumen with the partially denuded capillary due to ischemia and necrosis. So next, in terms of renal manifestations, is collapsing glomerulopathy. Again, again, this is quite a rare manifestation that has been associated with COVID-19. Whether it's because we're just not catching it because we're not biopsying these people who are very sick, or whether it's truly rare, I'm not sure. But it's hypothesized that either there's a direct viral effect or the presence of cytokines, again, that can lead to this collapsing variant of focal segmental glomerulosclerosis, or FSGS. And we know that in the United States, African-American patients with high-risk alleles of the APOL1 gene are already predisposed to this. So the association with COVID-19 is a little bit unclear. And in at least 3 of the studies that I read describing this condition in COVID-positive patients, the virus was not isolated on the kidney biopsy. So in this particular case from Kidney International, you can see that the patient was admitted with a creatinine of 1.2. By day 4, the creatinine increased to 4.4 milligrams per deciliter. He had a kidney biopsy, and then you can see here this glomerulosclerosis that's focal, and it's kind of classic. This collapsing variant on pathology that is described has usually a poor prognosis. So here I wanted to talk about some special considerations in dialysis requiring AKI. And I think this is the bulk of what makes AKI management in COVID patients unique. So just a general approach to the management of severe AKI, of course, appropriate volume resuscitation, use of diuretics for volume overload, use of potassium binding residents for hyperkalemia, and use of IV bicarbonate are all part of the conservative non-dialysis approach to severe acute kidney injury. The BICAR ICU trial, which I mentioned there, basically studied ICU patients with severe metabolic acidosis and looked at treatment with IV sodium bicarbonate, and in the majority of the patients, they found that there was no improvement in all-cause mortality at day 28. And they also looked at the presence of greater than 1 organ failure at day 7. And they found that for the majority of patients, IV bicarbonate did not help. However, in patients with acute kidney injury, which was a pre-specified subgroup, they did experience a reduction in those endpoints. And then, of course, communication with your critical care, your intensivist and pulmonologist is important in this situation in selecting lung protective ventilation strategies. And I wanted to mention in the next couple of slides, you'll see some text that's in purple, and that's my effort to highlight ways to manage some of these limited resources that we may be dealing with in a pandemic and with our hospital census surging. So if possible in these cases, I think delaying dialysis until it's absolutely required is always a good strategy. But in patients who are under investigations, PUI, persons under investigation for COVID, meaning that their test is pending, these patients, if it's possible, if you can delay dialysis until the COVID result returns in a few hours, then that would be an efficient use of your resources because they would no longer need to be in isolation necessarily. In terms of volume management, of course, using high-dose diuretics will help, and I'll talk a little bit more about that in another slide. And then trying to minimize nursing exposure without compromising patient safety should always be a goal during this pandemic. So there's no strong data to support early initiation of renal replacement therapy in COVID-19 associated kidney injury, but we know that these patients are very clinically tenuous, so have a low threshold to start dialysis if necessary. As is the case for any case of acute kidney injury, the indications to start dialysis are oliguria or anuria, respiratory failure, volume overload, which is the most common indication to start dialysis in COVID-19, hyperkalemia, metabolic acidosis, and uremia. And here on the side, I've mentioned the furosemide stress test, which is my favorite thing to do because it has prognostic value. So when you get called on the inpatient service about a new consult who has diminishing hourly urine output, one thing I like to do to determine whether this person is headed toward dialysis or CRRT is to do this high-dose diuretic challenge with IV furosemide, 1 to 1.5 milligrams per kilogram up to 120 milligrams, followed by assessment of urine output for the next 2 hours. And this has been shown to be better than urinary biomarkers to predict the development of stage 3 severe AKI. So this is what I use to guide us in terms of whether someone is headed towards dialysis. If they make less than 200 mLs of urine after this high dose challenge, then they're more likely to require dialysis. So I will go through a couple of different modalities of dialysis, and hopefully maybe the people in the audience who are not nephrologists will find this useful. So CRRT, or continuous renal replacement therapy, is the preferred modality in hemodynamically unstable patients, but it's not as widely available throughout various hospitals as other modalities may be. The benefit is that it's easy to achieve negative fluid balance in these sick patients, and you can do this gently over a 24-hour period, especially in patients who are hemodynamically unstable. The downside is that it does require more resources, so it requires an ICU setting, 1 machine per patient, and 1 nurse per patient per day. In terms of the dose of dialysis, typically we use 20 to 25 mLs per kg per hour for the dialysate rate. But in purple, I've highlighted that when dialysate supplies are scarce and you have many patients who may require this, maybe after they've gone over their initial once you've basically achieved metabolic control, it may be reasonable to decrease the fluid rate so that you can preserve more resources. And then I will talk about this separately, but anticoagulation is absolutely necessary in COVID positive patients because of a very high rate, a prothrombotic state that they're in. One thing I also want to mention is that if the patient census surge overwhelms the CRRT capacity at an institution, then you can consider using CRRT machines for prolonged intermittent treatments. So instead of running someone on CRRT for 24 hours, you can run them for 8 to 10 hours and then use the machine for someone else after cleaning, of course. So I just wanted to show you the importance of having hospital protocols that are set in place with thought and deliberation and not with haste. This is particularly important during this pandemic, and this is just a screenshot of what our CRRT order set looks like in our electronic medical record system. So there are various modes of CRRT using diffusive and convective clearance, which I won't go in too much into detail, but at UCSF, the main campus, we usually use continuous veno-venous hemodialysis. And you can see here we have all of these pre-made solutions which contain various levels of potassium, calcium, and bicarbonate, and we can select the appropriate dialysate fluid depending on our patient's metabolic derangements. And then we have a pre-built order set for anticoagulations consisting of either heparin or citrate. So this is all very important because you don't want to order CRRT without ordering anticoagulation. So just a brief note about fluid management with CRRT and what our experience has been at UCSF. As you can imagine with CRRT, this requires the nurse to enter the patient's room every hour to adjust the fluid balance and ultrafiltration goals. And so in order to minimize nursing staff exposure during the pandemic, we've been using fixed volume removal rates. So I've written an example for you here. Let's say that you spoke with your intensive care team and would like to achieve a goal net negative fluid balance of 1.2 liters in a day, which is about negative 50 mLs per hour net negative. And so in order to achieve that goal and try to minimize the number of times that the nurse has to go into the room, we've been calculating approximately how much volume the nurse needs to account for with the machine. So for example, if a patient is receiving 50 mLs per hour of tube feeds and 300 mLs per hour with IV infusions and medications, the hourly intake will be 350 mLs per hour approximately. Of course, this evolves throughout the day depending on any changes, medication changes. And so if we want to achieve a balance, a net negative balance of negative 50 mLs per hour, then we tell the nurse that the fixed removal rate of fluid with the machine should be approximately 400 mLs per hour. And then we check in with the nurse at various times throughout the day to see if this is approximating the overall fluid balance goal that we want to achieve for the patient. So this is a useful strategy, I think, for nurses to have minimal or at least less exposure to the virus. Another strategy which I wanted to mention actually is, I'll show you a picture later, but you can also have the CRRT machine outside a patient's room so that the nurse can just manage it from there instead of having to go in every time and use more PPE each time. This is just a reminder for me to share with you a story about a patient I had, and to remind you that this is not a one-size-fits-all type of thing when it comes to treatment of AKI and COVID-19, and it's important to individualize patient care. So I had a patient recently who was a 65-year-old female. She had severe obstructive sleep apnea and was also morbidly obese with a BMI greater than 45. And she was admitted with severe COVID-19 pneumonia. And at the time that I was on the inpatient nephrology service taking care of her, she had been in the hospital intubated with for over a month actually, and her hospital course was complicated by ARDS and severe acute kidney injury. So at the time of our nephrology consult, her blood gases showed that her PCO2 was greater than 100 for the past month or so. And then her serum bicarbonate levels were up to the 40s to 50s range chronically for the past several weeks. And her baseline creatinine level was 0.7 milligrams per deciliter. And at the time of our consult, the creatinine was rising and she was becoming more oliguric. And what we noticed is that once she developed renal failure, her ability to compensate for this respiratory acidosis was diminished. And so we ended up starting CRRT on her with a solution that contained 35 milliequivalents per liter of bicarbonate concentration, which is pretty standard. And for most people, that's fairly effective in treating their metabolic acidosis, which is pretty common. But what we noticed in this patient is that over the span of hours, her arterial pH dropped to 7.15, and this was primarily due to the fact that her bicarbonate level, because of diffusion, had dropped from 45 to 35, and because of that, her pH dropped. And so she actually, in addition, while continuing the CRRT, she required an initiation of a concentrated bicarbonate drip at 75 milliequivalents per hour. And this is a pretty high rate. And in addition to this, as a result of the high sodium content with the concentrated bicarbonate drip, on top of this, she required a dextrose D5W infusion to manage hypernatremia. Then she required a calcium chloride drip to manage the resultant hypocalcemia that ensues when you fix acidosis. So you can see that this gets very complicated quickly, but it's important to individualize the management because not all cases of COVID-19 associated AKI are treated equal. The next thing I wanted to briefly mention is prolonged intermittent dialysis, which is basically a hybrid between HD and CRRT, and it can be performed with either type of machine. It's non-inferior to continuous renal replacement therapy regarding patient outcomes. The benefit is that you can use higher blood flow rates to reduce clotting and still limit the risk of hemodynamic instability. This does not need one-to-one nursing, so it may be better for places that are limited in resources. And you can run this treatment for about 8 to 10 hours. The challenge is the uncertainty in drug dosing that would be appropriate, especially for antibiotics or COVID treatments. Of course, intermittent dialysis you all are probably familiar with. It's widely available, allows treatment of several patients with the same machine. There's a reduced risk of clotting compared to CRRT because of the higher blood flow rate. But because it only runs presumably for 3 to 4 hours in a day, you may be less effective in reaching your daily fluid balance, which is, we know that's critical in COVID-19 patients. And the other downside to this is that it usually requires a dedicated dialysis nurse. So you may potentially be exposing the dialysis nurse in addition to the ICU nurse, for example, when you're having someone on dialysis. So this requires more staffing and potentially increases the risk of exposure, viral exposure. But one strategy you can use to minimize these risks is to consider the shortest duration of dialysis that the patient needs in order to maintain their metabolic and volume status. Peritoneal dialysis I'll mention, but to be honest, we haven't been using it necessarily for acute dialysis treatment in COVID-associated AKI. The benefits are that it's widely available and there are no clotting concerns, but protocols for acute start of peritoneal dialysis may not be in place at many centers. And this does require less nursing staff exposure, so that's good. The challenge in critically ill patients, of course, is that if patients have respiratory failure and require proning, then it would be challenging to do PD. And now I just wanted to focus on the most important thing, I think, which is the hypercoagulability that we see in patients with COVID. We know that all 3 complement pathways are activated by this virus and there's increased risk of extracorporeal circuit clotting. So the two most common options we have for anticoagulation are unfractionated heparin, which can be delivered systemically, or pre-filter for regional anticoagulation just of the CRRT circuit. So with the regional anticoagulation, the goal is to just anticoagulate the circuit and not the patient systemically. And so typically we've been starting at 10 units per kilogram per hour. I start these patients on heparin regardless of, I don't wait for them to clot. I just start it preemptively if they're COVID positive, because we know that the risk of clotting is very high. And then the other option would be to use regional citrate anticoagulation. This is more labor intensive for nursing staff because you need to have strict protocols in place and nursing training, etc. And in certain cases where patients really are clotting a lot, I have used both heparin and citrate simultaneously. So, and that does not necessarily come with increased bleeding risk, which I'll explain in the next slide. The last point I wanted to mention here is that the optimal vascular access with appropriately sized catheters is crucial to address any catheter-related problems. So regional citrate anticoagulation has been shown to be safer than heparin. It doesn't have the bleeding risk associated with it. It is associated with mild electrolyte disturbances like hypocalcemia and metabolic alkalosis. The challenge with this is that it requires a strict protocol. And this protocol should be carefully thought about and not hastily implemented. So this requires a lot of work from the intensivists, nursing staff, of course, nephrologists. And on the right side, I've screenshotted what our order set looks like with the citrate anticoagulation. So you can see how many steps this involves in terms of titrating the citrate drip itself, And then it requires a calcium chloride infusion to be run concurrently. For anyone in the audience who is not aware of how this works, or if you aren't a nephrologist, basically the regional sodium citrate anticoagulation works because the sodium citrate is infused into the inflow of the extracorporeal circuit, and it basically works by chelating calcium and thereby inhibiting clotting. And so IV calcium has to be administered systemically in order to maintain a normal ionized serum calcium. This is the picture I was referring to earlier. This is Dr. Anita Vijayan, who works at the Washington University in St. Louis, and she's very involved in critical care nephrology, and she's very active on Twitter, and actually posted, here you can see that the placement of the CRRT machine is actually outside the room in order to help nursing staff and minimize their exposure. So the last part that I wanted to talk about is the long-term effects of kidney injury and prognosis in COVID-19. So there's very limited data about this. Of course, we've been in this pandemic for just over a year now. So more research has to be done, but in China, in a single center study of over 300 patients, they reported that nearly half of the patients recovered from kidney injury within 3 weeks of onset of infection. And in this case, severity of pneumonia was a negative risk factor in the remission of kidney involvement. And in the US, studies have shown that fewer COVID-19 patients have recovered renal function than patients without COVID-19. The severity of pneumonia was commonly associated with a lower chance of renal recovery and lower remission of proteinuria or hematuria, but really the long-term recovery rate remains to be seen. This is just the trajectory of renal function in US veterans from the study that I had mentioned at the beginning of the talk. And this study actually just came out in January, and this looks at over 1,600 patients who had AKI out of the 5,200 patients that were studied. And you can see about 12% of patients received dialysis, and among those, about 20% continued dialysis after discharge. So the red here reflects the patients who were on dialysis. And then the discharge serum creatinine was higher than the pre-hospitalization baseline creatinine in about half of the participants with acute kidney injury. So this really highlights the need to monitor patients for CKD down the line. And so this, they just followed these patients for 30 days or so. So we really need more studies with more longitudinal follow-up. And I didn't get enough time to talk about kidney disease and, COVID-19 infection in people with existing kidney disease and dialysis patients. But just a brief point that we see a high incidence of COVID infection in dialysis patients with end-stage kidney disease, because the thought is that they have alterations in their innate and adaptive immune systems. And so many of our inpatients are actually dialysis patients who are COVID-19 positive, and many of them test positive in their outpatient dialysis units just because of the closed quarters there. So now in our outpatient dialysis units, we've actually implemented specific shifts for only COVID positive patients to be getting dialyzed in order to minimize exposure for other patients. So just in summary, some key points about kidney injury and COVID-19. AKI is common, often severe, and associated with a high mortality rate. It can occur for multiple reasons that I discussed previously, but we are still elucidating more. CRRT is preferred in hemodynamically unstable patients, and anticoagulation is essential. It's important to be creative when there are limited resources, and patient care, of course, should be individualized. I've just listed some helpful resources for management of AKI. If you want to take note, the American Society of Nephrology has a nice resource page with multiple tools on how to manage different situations. And I wanted to leave you with a hopefully a cautiously optimistic note. With the advent of the vaccine and hopefully development of herd immunity, we will be able to get over this pandemic soon. This too shall pass. It might pass like a kidney stone, but it will pass. Thank you. And if you need to contact me at any time, my email is below.
Thank you very much, Dr. Lalasa. You have given a very extensive and lucid talk about the involvement of kidney in COVID-19. And I'm sure all the audiences have appreciated that. As you know, she has talked more and more about the acute kidney injury in COVID-19. And I wish there are many nephrologists in the audience who could follow the intricacies of dialysis therapy and all that. But in a way, even the non-nephrologists can make out the problems of COVID and kidney disease. I don't find any questions in the chat box, but only thing is to let's set the ball rolling. Shall I start a few questions from my side? Dr. Larson have extensively dealt about the problem of acute kidney injury, but I would like to bring out a few questions which are very relevant to the general practitioners and also the non-nephrologists in this group. One is in the initial days of COVID, the first question that we were getting was, this is a disease where the ACE2 receptors are the pathway or the entry pathway for the virus. So should we continue ACE inhibitors and angiotensin receptor blockers? Is there any harm in doing that, or should we discontinue? This is the first question we were getting that. So do you have any explanation? Because that may be very interesting to the audience.
I think there was a lot of debate about that in the beginning, and some studies suggested that maybe we should discontinue them. But actually, if you look at the mechanism, the pathway of ACE and ACE2, ACE inhibitors actually don't affect the concentration, or they don't affect ACE2 like you would think. And so I can pull up the slide again, but essentially there were conflicting reports in various studies, and ultimately I think now the consensus is that they don't need to be discontinued unless there's another indication for it, like hyperkalemia or worsening kidney injury, for example. So there's no reason to discontinue ACE inhibitors.
Yeah, on top of that, if you discontinue, their basic diseases might worsen, like diabetic nephropathy. So exactly. That's why we advise them to continue that. So before I go on to my other questions, shall I ask some of the experts in the field of COVID and COVID-19 disease? Dr. Chilumuri, do you have any comments or any questions on this?
I can
a lot of experience in New York regarding the acute kidney injury and of course the large population of end-stage kidney disease patients undergoing hemodialysis in your center.
So first a comment about the ESRD patients. They actually did pretty well during the surge. So the number of infections, where there was a sizable number of patients who were ESRDs who got infected, but the death rate was not very high. And the belief is that in ESRDs, they don't get the cytokine storms that normal healthy people get. So we had a death rate which was actually lower than other groups compared to high-risk groups. So we expected most ESRD patients to die when they got infected, but they really didn't die. So in a way, that's a blessing for them that they don't put up a strong cytokine response. With ACE inhibitors and AKI, I think I agree with Dr. Varanasi. Don't stop them until you develop a complication. Like if they develop an AKI and have hyperkalemia, I would stop it. Otherwise, there's no reason to stop them. Yeah.
The other question to you is, what special precautions we have taken? We have a large dialysis unit, and people will be coming at in-center dialysis patients. Home dialysis patients may not have much problem, but in-center patients will be coming and going 3 times, 4 times a week. For such people, and also for the safety of your dialysis technologies, do you take any special measures?
I think Dr. Varanasi covered a lot of that, but so I think we are in a slightly different phase in New York. I think, first of all, most of our dialysis team got infected in the first wave, so they're basically antibody positive. So they're less nervous to go into rooms and do dialysis, number one. The dialysis units itself, we had to create some isolation rooms now, just to dialyze patients who may be COVID positive. For all admitted patients, they're all screened anyway. So currently in New York, every admitted patient gets a COVID test. So if they're positive, obviously they'll be treated differently. If they're negative, then you assume them to be negative. But we do get surprises. Sometimes they're initially positive, and then a few days later they may initially negative and later on become positive. So that's there. Yeah. Some of the things that Varanasi showed where they had the machine outside the room, we really couldn't achieve that. I mean, I'm very impressed that they could do that in San Francisco. We did not have the capabilities to put the machines outside and dialyze them from inside. So we basically had the tech or the nurse wear a full PPE and go into these isolation rooms and do dialysis. I think we did, in April surge, we didn't dialyze that many and had very high mortalities. We changed now. I think we dialyze them fairly regularly now. The death rate at that time was, as she reported in one of the Bronx data, was as high as 50%. It's dropped down to somewhere between 20 and 30% now. If you have AKI with ARDS, the death rates have come down. Some of the deaths that happened in April was probably capacity. We didn't know what we were doing. The hospital was literally slammed with admissions. So none of our protocols were working in March, April. I think we have much more control over the situation now. So outcomes are much, much better than before. Yeah.
I find that Ramesh, the nephrologist, with this. Do you have anything to your comments or any questions?
Sir, good evening, sir.
Yeah, good evening.
Yes, sir. Actually, there are actually in the dialysis unit in our CSR block where we handle COVID-19 and dialysis patients. Actually, not many AKIs we saw. We saw more of ESRD patients and getting infected and then admitted. And then, of course, the mortality was definitely less as the in US patient, but the mortality was less, but less AKIs and more of ESRD patients got admitted with.
I this question of ESKD rather than acute kidney.
Acute kidney injury. We had less AKIs than more ESRD patients we saw. But that was maybe a difference. Maybe I don't know, because they got infected.
Getting COVID.
COVID. Less AKIs. ASIs, yeah.
Less of documentation, not much of documentation, and so data has not been published about the incidences or prevalences of COVID-19 and acute kidney injury, or the number of people with end-stage kidney disease developing COVID-19 infection. That has been a big problem.
Actually, we did PD in COVID patients. Actually, we did in AMCU and then in not in CSR block, but in other wards. We did in AMCU just before we got the COVID-19 report. We did PD for so many patients. Maybe they are those patients where AKI is seen, but they are less.
Ventilation, mechanical ventilation, you can do PD. If they are on mechanical ventilation, PD becomes a difficult job. Especially as Dr. Lalasa has said, if they are in prone position, doing a PD becomes very difficult.
Difficult.
So
Yes.
that's why we resort to either slow SPED and sustained low efficiency dialysis, or the CRRT, as she has mentioned. So Dr. Kairam, would you like to give any comment or any question?
I think you're muted.
We are not able to hear you. I think you are mute. Unmute yourself.
Yes. No, I was just going to say I'm not directly involved in any acute care at all. I've been watching this disease for the last 11 months out of the computer and the internet. So I'm amazed at how much multi-organ involvement occurs. And I'm still intrigued about what is the direct injury from the SARS CoV rather than injury to the kidney from all the other things that happen in this disease. For example, something similar happened in the first 1.5 to 2 years of HIV infection. We thought most of it was secondary to secondary infections. It took almost 1.5 years before they realized there was direct HIV encephalopathy. Similarly, endothelial injury turns out to be very critical in direct HIV involvement. So because of what I have been hearing and learning about ACE inhibitors, vascular injury, endothelial injury, I was curious if there has been some observation of initial direct injury to the kidney rather than it is because of the cytokine storm that happens later on, vascular compromise, hypovolemia, etc. I wonder if there is some speculation, Lalasa.
Yeah, there's a lot of conflicting report about this because some studies, some people actually isolated viral particles in the kidney, and then, like I said, others did not. So it's really unclear. I think we now know the confirmed, like the receptor, the way that the virus enters the cells, but I don't know if, in terms of the direct toxicity of the virus, that still remains to be seen, I think.
Yeah, that is true. Not only damages the tubules, and the second thing is the ACE2 receptor is hyper expressed and hyperstimulated in people who are infected with COVID. And that is the reason why some people have shown that ACE2 blockade or the ARBs are beneficial in these people, and the mortality is reduced in those who are on these drugs. It's interesting for all the audience here, because most of the Indian people, they may not be knowing, people from India, but T.K.S. Rao, who was a very renowned nephrologist in Downstate Medical Center, New York. He was the one who first postulated about this collapsing glomerulopathy in HIV people. That was way back in 1982. I don't know whether Dr. Lalsa heard the name of Dr. Rao.
Yes.
He was a pioneer. Same pathology is now described in COVID-19, collapsing glomerulopathy. He first described that in HIV. Then it was called gay boys syndrome. Any other question? One more question from my side to Dr. Lalasa. So you frequently give in end-stage disease patients erythropoietin. Erythropoietin is a thrombogenic substance. So these people with COVID-19 and they are on end-stage renal disease, they are anemic. Most of them are on this drug. So again, if you give erythropoietin stimulating agents, EPOs, then do you expect any problem in them, an increased thrombogenesis, and they're going into further complications? What is your practice? Are you treating anemia effectively, or are you leaving them because of the problem of erythropoietin?
That's a really good point that I've thought about myself, but I haven't been able to find a definitive answer. I think in at UCSF, we've been giving erythropoietin for people who have sustained AKI and worsening anemia, just because the only other option in those cases is to transfuse them blood products.
Not be a big problem. It's a big problem in ESK.
In ESRD as well, yeah. We've been giving it, but I don't know if there's the right answer to that.
One question to the various intensivists around is, a lot has been said about the high dose vitamin C or the ascorbic acid as a part of several regimens for treating COVID-19 critically ill patients. And the problem is, you discussed so many things about AKI, propofol and all that, but you didn't discuss about ascorbic acid producing oxalate crystals, especially when you use 15 grams, 20 grams, or even 30 grams of ascorbic acid as a part of several regimens, or isolated high-dose vitamin C for people with COVID infection who are critically ill. Maybe Dr. Chidamuri will be able to give us more information about that.
We don't use it. We don't believe there's adequate evidence to use these high doses of vitamin C in critically ill patients. People are using it and give anecdotal evidence that, oh, it did miracles. I don't believe it. Somebody has to do a decent study because it's really a high dose of vitamin C, and it has to be given intravenously. There's not adequate availability in the market to give that high doses of vitamin C, even if you want to, at least in the United States. So we don't give it, so we do not have experience with it at all. Yeah, Europe. In the United States, there are several critical care specialists who talk about it, who speak with news reporters, but don't publish it. And until they publish it, we will not use it. So Dr. Varanasi, do you use high doses of vitamin C?
I was going to say, I agree with you with what you just said. I've seen, I think it's maybe dependent on the ICU attending that's on service, because I've seen it a couple times, and I know some of the critical care surgeons use it in combination with high dose steroids. In those cases, even when it's not related to COVID, I generally try to encourage them to stop the vitamin C because I have seen a couple of cases of biopsy-proven oxalate nephropathy.
Yeah, one very common and very interesting question is, what's your take on vaccine, COVID vaccine in patients end-stage kidney disease and post-transplant, solid organ transplant? Because I know your doctor does more than 1,000 solid organ transplants in a year.
Yes. In speaking with my transplant colleagues, everyone seems to be in support of the vaccine for transplant patients, and then in ESRD patients as well. And they're actually we have kind of like a slower rollout than other institutions for the vaccine, but the top tier of patients includes patients over 75 as well as ESRD patients.
Same thing with us. We've only given it to ESRDs who are over the age of 65, and it has been tolerated quite well. We haven't seen any problems with it. I think what's unknown is how well do they develop antibodies, ESRDs. If you take other vaccines like hepatitis B, they don't always put up adequate antibodies. So I'm assuming that will be the same problem with ESRDs and COVID vaccines, but that remains to be seen. But over 65, we've given it without any problem. That's all we have given so far because we are restricted to ages right now. So we haven't given to the best of my knowledge, post-transplant patients, because they were either not over 65 or didn't meet the criteria for us yet. But our plan is to give it if they need it, if they reach that group.
Yeah, I think you need more studies, as I said. If having the hepatitis B being brought out, we give double dose for these people with end-stage kidney disease.
Yeah.
Instead of 25 micrograms, 3 doses, we give 50 micrograms, 4 doses, 1, 2,
Yeah.
3, and 6 months. So that way they develop antibodies, because we have checked the antibodies in these people and that is established. As far as COVID is concerned, we are not sure about this because this is too early in this.
Too early, yeah.
I do have one comment. The discussion that we had regarding high dose vitamin C also applies to so many other therapies that came out in the last 9 months. So Dr. Chilumuri says, we don't use vitamin C. And he made a very good point that some researchers, some doctors seem to be talking to newspapers before they publish. Dr. Varanasi says that you don't use vitamin C, and sometimes you would actually stop somebody who's using vitamin C. So I think, Dr. Raviraju, you're in a unique position to stop those doctors who talk to newspapers before publishing. There's an incredible opportunity to publish in this area, as Dr. Chilumuri has done in the last 7 or 8 months. So as long as there is number of patients, faculty, postgraduates, there's an unbelievable opportunity to make observations and publish. Because I'm not directly involved, but I see incredible amount of inaccurate information that confuses the public. So I think the senior people on this panel have great responsibility to stop worthless therapies that only confuse the population. I mean, Dr. Sudhakar, I thought we were coming to the end of it, so I wanted to put in my 2 words, not to talk to too many newspaper reporters. Now that Mr. Trump is gone, there'll be slow news days.
This is our published data. This is not newspaper. Several authentic publications are there on this.
Yes.
You can just go through. That's why we raising this question. There are these very well reputed journals they have published.
I am saying that's how only it should be, rather than the tremendous amount of misinformation that came out in the beginning. So I'm just begging for people to be a little slow in implementing, their own experience without peer-reviewed journal publication.
So any more questions from anybody else?
Dr. Lalasa, just one question, maybe a last question.
Sure.
Hello.
Go ahead.
Hello.
Yeah.
I guess, is there any category of patients with kidney disease, for this person, vaccination, you should not vaccinate them? Is there any category of those kind of patients with kidney disease, dialysis, transplant, on immunosuppression? Is there a category of patients where you don't advocate vaccination?
I can't think of one because this is not a live virus vaccine. So I don't think there's a category of kidney disease patients who can't get the vaccine, to my knowledge.
There is no contraindication, right? General contraindications only. Contraindications for anybody else.
Okay, thank you.
Yeah.
Thank you, sir. Thank you.
So if there are no more questions, I think we will wind up the session. I thank Dr. Lalasa Varanasi and also congratulate her for a wonderful lecture she has given, and also for waking up very early in the morning and taking all the trouble to address the audience. Thank you very much. And I thank Dr. Sudhakar for giving me this opportunity to interact with you all and also moderate the session. Thank you very much.
Sir, before winding up, I have a small comment to make. I was just listening to Dr. Ramesh saying that it is the end-stage renal disease which we have seen more often than the acute kidney injury. Now that here is the challenge for him, that now that we have 1,600 case records with him in the CSR block in our own hospital, maybe it's time that they should go back and see as to how many of them had acute kidney injury and how many of them were with the ESRD, and come out with actual statistics rather than the anecdotal representations. So with that, as the last point, I wish to thank Dr. Lalasa Varanasi again profusely for obliging us to wake up early in the morning and sharing his expertise with us, and also Dr. Ram Mohan Kairam and Dr. Ravi Raju for so ably doing this, moderating this particular session, and for Dr. Sridhar Chirumuri for chipping in with his expert comments. With these few words, I wind up this session and invite you for the next week's session on 31st of this month with another topic. Till then, bye-bye.
Bye.
Thank you, everyone. Bye.
Okay, bye.